Distinguished faculty members, distinguished professors, who are first time they're hearing to listen some talk, what's going on, and dear students. And in the absence of Professor S.K. Satish, I request Dr. J. Srinivasan to welcome the people. Srinivasan, just to say that he's the founder of this institute, the DVHA Center Climate Change. He did his, for the other people who don't know him, he did his ITC graduation in Chennai. Then he went to New York, did his MS. Then Stanford, he did his PhD. And is an atmospheric scientist, very well known, and in NASA also. And we're lucky to have him here starting this department. About 15 years now, 15 years this department started. Is about 15 years this department started, the DVHA Center? Yes, 15 years. 15 years. And he's a man, what he preaches, he practices. We all know the carbon footprint, you have to reduce 2 ton carbon footprint per person per year. To match that one, he walks from house in Malaysia to here every single day. And as a man in academic thing, he green signal always will be there. He guides us so much, corrects us so much. It is always a pleasure to communicating with him. And more than that, many people may not be aware of it. His uncle, none other than Nobel laureate Sir C.V. Raman. So I have a great pleasure to you, sir. Come and formally welcome the people and the speaker.
Good afternoon to all of you. As all of you know, Dr. Paramesh has been organizing this monthly talk by eminent doctors over the last 3 years now, covering all aspects of health and environment. And we heard some very fine lectures. And today he invited an eminent doctor, Dr. Darshan Krishnappa, to talk about one of the most important issues, which is cardiovascular disease. And I'm sure Dr. Paramesh himself is aware because he went through a crisis a few months ago. Okay, so this is a very important problem in India. You look up any statistics, India has one of the highest rate of cardiovascular problems. And the awareness level, even among the educated, is not very high. And I find even among my friends and colleagues, people are reluctant to undergo regular checkups, which can avoid all difficulties. So it's very important that we listen to an expert about the risks involved and what kind of precaution to take. Because to me, there are many risks as you get older, okay? There are some which you can do nothing about, like some cancers, for example. But cardiovascular risk is eminently manageable. And the best example is Dr. Paramesh. He underwent a major bypass and he's still playing tennis. So this tells you this is something which is eminently preventable. And so everybody has listened to the eminent doctor to make sure that you regularly go for checkups so that if you are unlucky and a minor problem develops, you control it at the early stage so that you can live a normal life. So I'm very happy that Dr. Paramesh managed to get Dr. Krishnappa. I request him to introduce the speaker.
Thank you, sir. Again, distinguished audience, this is the monthly program, as Professor J. Srinivasan said, the Wages and Climate Change in collaboration with the Lakeside Education Trust and International Pediatric Association, headquartered in Geneva. About 1 million pediatricians are there. We are organizing monthly program here. And so next subject, just to highlight the sensitizing the issue before the speaker taking it over. We all know, I think our 20-year data been published in 2002 until 1970 to 1999. There I hypothesized air pollution seems to be the cause. Increased density of population, industries, and automobile. We hypothesized this might be due to air pollution related to that change of demography. Everybody laughed at it. Now we all say air pollution, global warming, climate change, they are totally interrelated. Each chemical we can identify now, tell this is the cause major. So we have progressed so much. 2017 WHO says that air pollution has got an impact from womb to tomb. And nearly 46% of the chronic lung diseases, 24% of the lung cancer, 25% of heart attacks, 20% of the stroke are related to the air pollution. And now, apart from that, now we have behavior changes, mental problem, whole lot of things are coming there. Endocrine problem, obesity are related to that also, air pollution. Now, having said that one, I like to suggest a few points that each 10 microgram per cubic meter greater exposure of 2.5 micron in children and adolescent significantly associated with 2 to 4 millimeter higher systolic blood pressure. The recent data shows from American study. There is 55% greater odds for development of the hypertension in these children. Prospective birth cohort studies of 1,200 pregnant mothers to PM 2.5 is associated with increased blood pressure between the age group of 3 to 9 years in children. Hypertension in children 3 to 9 years. So cardiovascular health is positively associated with traffic density and proximity to the main road where you live, and negatively associated with access to green spaces, parks, and recreational facilities. So what are the risk factors? How we can predict? What are all the mitigating measures and fill up the gaps in the knowledge? It will be covered from one of the experts. We have a great pleasure having him here. He's such a busy man, hardly he have time. You will get about 5 minutes, is very difficult to get him. He's such a busy man. He is none other than Dr. Darshan Krishnappa, is a consultant cardiac electrophysiology from the Manipal Hospital, Mallige Medical Center. He did his MBBS in Bangalore Medical College, did his MD in All India Institute of Medical Science. He's a merit seat. All through he's a merit student. He got the merit seat, and also a DM in cardiology from Chandigarh. And his field of interest is heart rhythm device therapy, including defibrillators and respiratory synchronization therapy and lead extension. The sudden cardiac arrest, prevention and management, his specialty. Complex arrhythmias, management including atrial fibrillation, ventricular arrhythmias, it is specialty. Arrhythmias in patients with congenital heart disease, children who are born with the heart defect, arrhythmias will happen. How manage? He is an expert in that one. And also syncope, how to manage it, and heart failure, how to manage it. He's going to talk about it. And he got many fellowships and membership. Important of them: Heart Rhythm Society, American College of Cardiology, European Heart Rhythm Association, Indian Heart Rhythm Society, and he has many publications at national, international level. He did his fellowship in Madison, Wisconsin, is it? Oh, okay, fine. So I have a great pleasure extending invitation for you so that we can learn from him how best we can manage as a common man. So over to you, sir.
Thank you for those kind words, sir. So, having graduated from the temple, what I consider the Temple of Indian Medicine, to be invited today to the only bigger center in India for me, the Temple of Indian Science, it's a matter of prestige and honor. Thank you for that.
What color? Okay, provide.
So I think as has been appreciated widely now, cardiovascular disease is the leading cause of death. And this is a global phenomenon. And this has been existing, it's been this way for several decades now. And that's also been one of the reasons why heart and heart-related illnesses has received a lot of attention, both in terms of number of people who are looking into it and researching into it, and also in terms of funding from different agencies. It accounts for nearly 30% of all deaths and up to 40% of premature deaths. So, what we mean by premature deaths is death before 70 years of age. Amongst cardiovascular deaths, 85% of them are related either to what is referred to as coronary artery disease, or in layman's terms, heart attack or stroke. Now, when we look at the numbers, there has obviously been an upward trend with increase in numbers with time. But when we look at age adjusted death rates, it is actually decreasing. So one of the main reasons why the numbers has increased is because the population is aging everywhere. Now, the rates of decline is something that's been consistent both among males and females, and this largely reflects the advances both in terms of technological advances, better understanding of disease, and also the tools that we have to treat them, either be it medications, a better understanding of lifestyle risk factors. As sir was pointing out 20 years back, when someone said air pollution is causing this, people laughed it off. But today it's there on everyone's mind, including the World Health Organization. But this rate of decline is something that is varied in different regions. Now, when we look at the age standardized death rates, the highest rates of cardiovascular deaths occur in Central Asia and in Eastern Europe, along with some of the African countries. When we look at the rates of decline, this rate of decline is most prominent in high income countries, which tend to be the Northern American countries and also some of the Western European countries. It almost flatlines in the sub-Saharan African countries. And even when we look at the Asian countries, they're represented by the orange line. You see that it's more or less flattish with only a very slow decline. This again reflects one, the increasing number of risk factors. And I think environmental risk factors is something that is very often overlooked or used to be neglected. And also the lack or the disparity in distribution of healthcare resources even among the Asian countries. So when we look at the risk factors, it traditionally is classified into those which are not modifiable, really are age, sex, gender, race, which we really can't do anything about, and modifiable risk factors, which are really the cornerstone of all preventive strategies. Now, the only way you can prevent any disease is to start early. Sir was saying womb to tomb. I mean, that's the mantra, and that's been really replicated, and the results have been replicated in a number of epidemiological studies, including the ARIC studies, which have really shown that there's a legacy effect for a lot of these risk factors and there's tracking of these diseases. For instance, if you are hypertensive when you're young, there's a significantly higher risk that you're going to be hypertensive when you're older. Same thing applies for obesity, same thing applies for diabetes. So in terms of modifiable risk factors, for several decades, the real emphasis used to be on a lot of the comorbidities which tend to predispose to heart disease, be it hypertension, diabetes, a lot of emphasis on smoking. But it really wasn't a wholesome evaluation. Now, the term exposome was actually first coined by Christopher Wilde. This was actually coined in the context of cancer and oncology, where he introduced this concept to actually bring upon bring upon the limelight on environmental risk factors, where largely the focus in malignancies at that time used to be on the genome. And accordingly, you had the Human Genome Project, which came up, where there was a lot of research to try and identify which genes are predisposing to malignancies. So he introduced the term exposome, one, to shine the light on all the environmental risk factors, not just the prominent ones. So exposome really talks about the exposure of an individual in his lifetime, right from prenatal days to all the environmental risk factors, not just the prominent ones, but all of them. And accordingly, he divided the risk factors into three main categories: the internal environment, general external environment, and the specific external environment. Now, by the internal environment, what we mean is basically the chemicals that are produced and released within the human body from metabolic pathways, from inflammation, from the gut microbiota. General external environment includes the climate, includes the society you live in, the psychosocial factors involved. And specific environmental factors include infectious agents, smoking, lack of physical activity, and the sort. Now, while this was advantageous in that you were now talking about a wholesome risk assessment as opposed to just focusing on one or two of the important risk factors, there was considerable overlap between the three. At the same time, we were also talking about the internal environment, which was more likely a consequence of a lot of exposure to the external environment rather than being a consequence by itself. So this evolved into the envirome concept, where you started talking about the entire human environment. So in biology, environment refers to all external conditions, social, cultural, economic, that affect the nature and survival of an individual. So in the environment concept, you basically have three domains. You have the personal environment, you have the social environment, and you have segregation into the natural environment. Now, for all intents and purposes, most of preventive strategies, most of awareness programs have all largely focused on the personal environment, where everyone talks about smoking, you talk about diabetes, you talk about hypertension, physical activity. Things that have largely been ignored has been both the natural environment and the social environment. So by natural environment, what we mean is, and for me, the most important thing which has been really underappreciated is the circadian rhythm or the night and day cycles, seasons, sunlight, altitude and latitude, green spaces, as Dr. Parmesh was mentioning. Social environment, we're talking about the local infrastructure. You have pollution, both air and noise pollution, social networks, and socioeconomic status. So for this talk, I'll largely be talking about natural environment and the social environment. I think personal environment is a completely different talk by itself. So the first and most important, in my opinion, about in the natural environment is the circadian rhythm. So the circadian rhythm is one of the most primordial natural processes there is. It is something that is seen in plants. It is something that is seen in all animals, and something that affects virtually every organ in all human beings. It is yet probably the most neglected and poorly appreciated. Now, as we move forward, you'll appreciate that the circadian rhythm is something that really acts on every cell in the body. You have two clocks, the central clock, which is really the suprachiasmatic nucleus in the hypothalamus. And this is the only portion of the circadian rhythm that is light sensitive. And it receives its input from the retina. And this is what largely directs the peripheral clocks and all the organs. Now, the peripheral clocks are present in all tissues and organs. Their primary input or their primary influence is from the central clock and also from all other external factors. For instance, when you eat, when you sleep, your physical activities, metabolites in blood, and these are all what influence the functioning of these organs. So you really have one master control, which is your hypothalamus, which controls the peripheral organs via metabolites and other via hormones and other humoral factors that are secreted into blood, and also via activation of the neuronal systems. The non-central clock factors, especially the most important one, is your eating behavior, your activities, and your sleep patterns. And sleep is also now being accorded a lot of importance and has recently been incorporated into the Life's Essential 8 by the American Heart Association. So the molecular mechanism by which the circadian rhythm largely involves four primary genes within the suprachiasmatic nucleus, which in response to input that they receive from the nucleus is involved in the transcription of various factors, both nuclear and cytoplasmic factors, which ultimately lead to expression of different hormonal and humoral factors. These factors are also influential in affecting the sympathetic and parasympathetic nervous systems and the output of these systems. So as I mentioned, the circadian rhythm is something that is present in all organs. And similarly, the heart is no exception there. You have a circadian rhythm for every normal function of the heart, be it your heart rate. Your heart rate has a normal oscillatory pattern during the 24-hour cycle, where you have lower heart rates during the night when you're asleep, and you have faster heart rates when you're getting up in the morning. And this is not just because of the stress of waking up, but it is also because of all the other factors which are released into the blood by the circadian rhythm, which is directed by the central clock. Similarly, your blood pressure has oscillation of its own. It has two peaks, one at 9 a.m. and one at 7 p.m. Your vascular tree, which includes both the vasomotor tone and the endothelial function itself, also exhibits an oscillation. Similarly, your clotting factors. So all of these factors are what really contribute to the occurrence of a heart attack. Now, as all of us know, what we mean by a heart attack is a clot forming within the blood vessels of your heart and clogging off the blood vessels. So there's no blood flow to the muscle. So when you have variations occurring in the vascular tone, when you have variations occurring in the clot forming process itself, there's bound to be a natural variation or a time dependence of the occurrence of myocardial infarction. And accordingly, we really see two peaks there too. One between 6 a.m. and 12 p.m. and the second between 6 p.m. to 11 p.m. Now, not only is there a variation or an oscillation in the occurrence of these events, but it has been postulated that even the severity of the event is really dependent on the time at which it happens. Now, some of these studies have largely been observational studies, and it's very difficult to control for confounders in such kind of studies. So, what has been seen is if you have a heart attack at night, there's a greater chance you have more muscle damage as compared to when you have a heart attack in the morning hours. It's possible that you have a much lower response at night from the healthcare team, and that may also be contributing to it. But even in animal studies, when you ligate the blood vessel to the heart during this wake to sleep or sleep to wake transition, you tend to have a bigger amount of muscle injury. And this is all because of the circadian rhythm, again, that you have in each of the myocardial cells, which also leads to variation in what we call ischemic preconditioning. The most visible impact of disruptions in the circadian rhythm is observed in shift workers. What has been seen is that these individuals tend to have higher prevalence of diabetes, higher prevalence of hypertension, higher prevalence of cardiovascular and cerebrovascular disease, and also arrhythmias like atrial fibrillation. Not only this, there is also a dose response kind of a relationship there, where the greater the frequency of changes in shift, the higher the prevalence of these conditions in these individuals and the higher the risk involved. So what do you do and how do you prevent? Prevention is my main mantra for treating heart disease. And there's very little you can do when someone develops a heart disease. You put in a stent, you do a bypass, you give some medications to maybe slow down the progress. The first thing you need to do for maintaining circadian health is avoiding change in your routine practices. And this is something that's being increasingly advocated. Get up at the same time, sleep at the same time, make sure you have regular eating habits. And this is not something that is only unique to the heart health. It's also something that's very commonly prescribed by your gastroenterologist. It's also something that your doctors tell you when they prescribe medications that you need to take it at specific times. Now, one reason for that is the half-life of the drugs. But it's also because of chronotherapy, which is increasingly being described in some studies, that the effect of the drug tends to be more if you're taking it at the exact particular time, as opposed to if there are variations in it. Moving on to the next one, I think the second one, which is gaining increasing traction in public life today, is residential green spaces. We're seeing a lot of apartments that are advertising about the green spaces involved and even layouts that are talking about the greenery in their projects. Now, there is a real scientific reason for that. Now, evolutionarily, like all other animals, we developed in a green environment. We grew up. Rather than grew up, our ancestors, our initial ancestors, evolved from there, and accordingly, our genes are adapted for that kind of lifestyle and that kind of environment. Now, epigenetic changes do happen in an attempt to adapt to changes that happen in life, but that tends to compensate for change only when the change is slow. So when there's a drift, it works, but when there's a sudden shift, as has happened with urbanization and the changes in human lifestyle, those epigenetic changes can no longer compensate for the sudden shift in lifestyle. So several studies have looked into it, again, largely observational studies, and there are limitations associated with any observational study, which have seen that people who are living in the greenest areas of a city or a state, as opposed to those living in the least green areas, there's a nearly 15% increase in risk of cardiovascular disease. And this has also been replicated in the Nurses' Health Study and the British Heart Study, where they saw that those people living in greener areas tended to have lower risk of cardiovascular disease. Now, the only prospective study which happened was a natural experiment. It was when the emerald ash borer entered the United States. This was in 2002. The emerald ash borer is a forest pest. So between 2002 and 2007, it led to the loss of 100 million trees. What they saw there was during that period, there was 16.7 excess deaths, which could be attributed just to the loss of these tree canopies itself per 100,000 adults after controlling for all other factors. So this is really the only direct evidence we have. All others comes from indirect evidence through observational studies and other cross-section studies. The next big topic here with cardiovascular risk factors or the natural environmental risk factors is climate change. And this center knows more about this than probably even I do. But temperature has long been recognized as a risk factor for cardiovascular disease. In fact, we used to advise, I did my DM from the Postgraduate Institute in Chandigarh, and we used to tell some of our patients in whom you couldn't really open up the blood vessels, maybe because of a lot of calcium, very diffuse disease, to move to more warmer climates during winters and to come back during summers. Now, that's because of the influence cold has on the blood vessels. And that is something that's been really understood well and demonstrated consistently across studies. Now, the association between hotter temperatures and cardiovascular risk was something that was inconsistent. But nowadays, with the changes that we see with global warming, we are increasingly seeing, especially in a lot of newer studies, a more consistent effect of hotter temperatures on cardiovascular risk too. Now, non-optimal temperatures contribute to 5 million excess deaths per year over and above all the other risk factors. When we look at the relationship between temperature and cardiovascular risk, it's a U or a V-shaped relationship with both extremes being associated with a higher cardiovascular risk. And you have a minimal mortality temperature, which is the ideal temperature at which you have the lowest mortality rates, being ideal for cardiovascular health. Now, both hot and cold temperatures tend to cause neuronal activation, where they lead to sympathetic activation. They also contribute to a hypercoagulable state, thereby setting a stage for clot formation in your blood vessels at the same time, increasing the oxygen demand of the heart muscle. When both act together, you're just stepping up for disaster. A number of studies have looked into the influence of temperature. Again, a lot of these are observational control, case control of cohort studies, which have all shown consistently a greater effect of colder temperatures than hotter temperatures on cardiovascular risk. A number of meta-analysis have looked into these studies. Now, one challenge with a lot of these studies is there's a lot of heterogeneity in their definitions for what cardiovascular events were and also what hot or what cold was. Keeping that in mind, these meta-analysis, multiple of them have been done, which have shown a 1.5 to 2.5% increase in risk of cardiovascular risk for every 1 degree rise or fall in ambient temperature. Arrhythmias, similarly, you have higher rates, and we've seen this both in terms of atrial arrhythmias and ventricular arrhythmias in patients living with implantable cardioverter defibrillators, where colder temperature again tends to exert a greater influence in occurrence of these arrhythmias. Now, when we come to the extremes of climate change, which are heat waves and cold waves, and this is again something we're seeing a greater frequency of them. We're seeing longer durations, and we are seeing a greater distribution. We're seeing heat waves and cold waves occurring in areas which were not happening previously. Now, these also accordingly increase risk of cardiovascular events, especially acute coronary events, which is basically what we mean by that is heart attacks. So what needs to be done? Climate change is something that needs to be approached in an integrated fashion. There are multiple stakeholders, with each having an important responsibility in this. You need change right at the policy level, with the government and administration playing a key role, not only in taking up the topic, but also in enforcing and having a lot of accords, sticking to promises made at accords, which is something which we don't see even as of now. You also need a lot of stakeholders, the doctors being stakeholders here, but at the same time in India, we probably don't see too many doctors coming in and trying to be part of the movement. I think that is something that needs to change because we're, like everyone knows, at an inflection point where even if we don't do anything now, we're only going to be seeing irreversible damage. Some of the other natural risk factors include seasons, and this has been seen consistently for several decades. Cardiovascular diseases tend to be more common in the winter months. Again, because of the effect of cold, where you have more coronary vasospasm, more inflammatory activation, and also a greater hypercoagulable state. Increased exposure to sunlight has been shown to protect from cardiovascular disease, this especially when it starts off at a younger age. It has been attributed to increased vitamin D synthesis. Now, some of the randomized control trials have really failed to show proper benefit of vitamin D, but multiple studies, especially observational studies and even cohort studies, have shown the value of vitamin D supplementation and the relationship between vitamin D deficiency and cardiovascular disease. Now, coming to the most important social environmental risk factor, air pollution. I think this is something that today is appreciated by everyone, but again, something that hasn't enforced a lot of policy change or something that we don't see the general public really being aware of or talking a lot about. It's a rapidly growing health hazard and has been designated as the second most important cardiovascular risk factor by the World Health Organization. The most important being age. So that's a non-modifiable risk factor. Previously, we used to say that smoking is the second most important risk factor, and today, clearly, air pollution has overtaken it. The fact that you're living in Bangalore itself makes you a smoker. Whether you smoke or no, stepping out onto the road, your exposure is similar to a smoker. At a point in time in Delhi, being a resident of Delhi was equivalent to smoking 1 pack of cigarettes a day. So that's the kind of risk you're putting yourself because of the levels of air pollution we see in most of the Indian cities. It's consistently been shown to be associated with higher risk of ischemic heart disease, both chronic in terms of development of atherosclerosis itself and the process of cholesterol deposition within blood vessels, and also acutely in terms of what we call plaque rupture, which eventually leads to a clot formation and the complete occlusion of blood vessels. It also contributes significantly to decompensation of heart failure in patients who are living with heart diseases and to stroke. Now, when we look at the contribution of air pollution to death, there's a significant variation across regions in terms of diseases or immediate causes for death, with a greater contribution from cardiovascular disease in the developed countries and a lesser contribution in less developed countries. But on an average, it accounts for around 30 to 35% of all cardiovascular or all air pollution related deaths are cardiovascular related. Now, when we look at the impact of air pollution, you lose nearly 3 years of your life because of air pollution, which is significantly more than what smoking does, what infectious diseases do, or what violence or warfare does. Yet the focus on air pollution still isn't where it is or where it needs to be, especially when you compare it with the focus that's been on smoking. Now, every packet of cigarette comes with a serious health warning. Every movie you watch in the theater comes with a advertisement raising awareness. I think we've reached a stage where air pollution needs the same sort of impact, simply because you're being exposed to it whether you like it or not, and because you have a greater number of pollutants that are causing greater damage. Now, when we look at the constituents of air pollutants, you have particulate matter, you have gaseous matter. I won't go into the details of this. The World Health Organization standards for particulate matter, PM 2.5, is an annual standard of 10 and a 24-hour standard of 25. Now, the standards in the United States is 12.5. The standards in the European Union is 25. In India, fairly recently, it was revised. Our standards are 40 and 60. Now, when we look at the trends across PM 2.5 levels across India in the major metros and major cities, you see that we are almost, even the troughs of these curves are above the WHO cutoffs. Now, the relationship between air pollution and cardiovascular risk is exponential. So when you just look at the two or compare the two standards of developed areas, the US and the European standards, you have a significant difference in the cumulative 3-year risk of development of atherosclerotic disease, even with those countries which have significantly lower limits as compared to what the Indian standards are. Pathophysiologically, the most important mechanism by which air pollution causes atherosclerotic disease is by oxidative stress and inflammation, which is all largely initiated in the lungs at the alveolar interface with the subsequent systemic spillover. You also have activation of the pulmonary neural arc, which leads to sympathetic activation and activation of all our hormonal systems, which contribute to pathologic processes. More recently, the impact of pollutants on circadian dysregulation has also been reported, with decreased amplitude and even decreased in oscillations of the gene expressions involved. So as I mentioned, it's the second most important risk factor today as per the World Health Organization. For every 10 microgram per cubic meter of increase in PM10 levels, you have a 12% increase in coronary events and a 13% for every 5 microgram per cubic meter increase in PM2.5 levels. All studies, all meta-analysis show consistent reports of increased risk to all air pollutants with the exception of ozone. This is one of the meta-analysis which included more than 20 studies, and you can see that there's a significant increase of nearly 4.5–5% with each of the air pollutants involved, with ozone being an exception. Not only acute coronary events, but also heart failure. Air pollution increases the risk of decompensation. It increases the risk of hospitalizations. It increases the occurrence of arrhythmias in patients who are living with heart failure. And we know that patients with heart failure arrhythmias tend to be one of the sentinel events, which ultimately tends to be fatal. You have 11% increase with every 10 microgram per cubic meter increase in PM2.5 levels. And you have a 22-month gain in life expectancy if the World Health Organization limits are followed, which is an annual standard of 10 and a 24-hour standard of 25. So if you follow this, you're going to gain 22 months. And even below these levels, there's a consistent increase in risk with increasing PM2.5 levels. Similarly, we see an increased risk with arrhythmias, both atrial and ventricular arrhythmias. And these are some of the factors which ultimately contribute to or predispose to stroke. So what needs to be done? Again, you need to enforce changes at a systemic level and at an individual level. At an individual level, what you can do is obviously avoid traffic in our city as much as possible. Now, there was some controversy about exercising outdoors. So this was again recently studied in Europe, where they looked at the impact of exercising outdoors, and they saw that the health benefits of exercise was still preserved even in those individuals who exercised at moderate PM2.5 levels. Now, there was a threshold there. So if you cycle for more than 1.5 hours, or if you walk for more than 10 hours a day, your health benefits were overridden by the hazards of exposure to air pollution. Now, the second component here is when we talk about pollution is noise pollution. Again, noise pollution is something that we just ignore as something that is just a nuisance value rather than really attribute health value to it. It is an emerging health hazard and is increasingly being given importance, especially in the European Union, with the European Commission coming up with a lot of regulatory framework in terms of how your road surfaces should be, how the tires should be to minimize noise. Road traffic noise is the major component here. The data with regards to aircraft noise or railway noise is less clear because you don't have too many studies. And similar to other forms of pollution, noise pollution has also been shown to be significantly associated with a higher risk of coronary artery disease. Now, this was a study of nearly 500 patients where they tried to understand how noise pollution was leading to cardiac events. So what they saw was they basically got a FDG PET scan in all these patients after exposing them to noise. There was greater degree of amygdalar activation, and this ultimately led to activation of the hypothalamus, leading to variations in the circadian rhythm, leading to disturbances in hormonal outputs, all of which leading to inflammatory responses and dysregulation of organ systems. Each 10 decibel increase was noted to be associated with an 8% increase in risk of coronary artery disease. This was a meta-analysis that included all studies that looked into the relationship between noise and cardiovascular disease and stroke. In both cardiovascular disease and stroke, there was a significant increase in risk with nearly 5 to 10% in some of the high quality studies were noted. The pathways involved, you have a direct pathway, you have an indirect pathway where noise leads to some form of stress and activation of the stress mechanisms, which is both your neural systems and also the hormonal and humoral systems. Your stress responses ultimately lead to the same factors that have traditionally been regarded as the important risk factors, cause hypertension, cause dyslipidemia, cause diabetes, and ultimately leading to cardiac events. So what are some of the things? Again, the central concept for mitigation remains the same. Personal level and at a systemic level. At a personal level, have more barriers. You can use noise barriers. Again, keep away from noisy environments. At a systemic level, have greater standards or different standards in terms of building construction, greater or better design, especially design of smart cities, which is going to be consistent in terms of mitigating risks associated with other environmental factors too. If you have a smart city where you don't need to travel too much, you're cutting down your traffic time, which is also going to reduce your exposure to air pollution, which is going to reduce your exposure to noise, and which is also going to reduce your stress levels. So some of the other environmental factors, less important, less well studied and understood, include your social network, socioeconomic status, and the local infrastructures involved. So to summarize, the human environment is a complex multi-domain interplay. While traditionally most of the emphasis has been on personal domain factors like hypertension, diabetes, smoking, or physical activity, the importance of the natural and social environment is increasingly being recognized now. The circadian rhythm is the most primordial natural phenomenon common to both animals and plants and has a central role in the regulation of all organ function, both in health and disease. Circadian dysregulation is increasingly being noticed and being recognized both from pollutants and from lifestyle factors, and its impact on health is increasingly being emphasized on. Air pollution and climate change are now recognized as very important cardiovascular risk factors. We are seeing a lot of pre-existing diseases which were otherwise going under the carpet, which are being highlighted today. A multi-pronged effort is required, which involves multiple stakeholders. It involves your administrators, involves scientists, it involves your physicians, cardiologists who are involved in care of these patients, in coming up with strategies, both prevention and response strategies, and also in increasing awareness among the general public about the sinister effect of these risk factors. Thank you.
Congratulations, one of the finest talk we ever heard, and you covered most of the things. Now it's open for any questions, please. We have till 12 minutes, please.
Compelling evidence is there that air pollution causes heart attack. But our policymakers in Delhi don't seem to believe it. How do you change that?
So I think
What I want to ask you, Delhi has the highest pollution in 30 months in India. Has anybody compared the death rates in Delhi with, let's say, Bangalore or Chennai? And that should show up clearly, right? Because all the time they claim your data is from abroad, Harvard study and so on. Then after Indians, these guys are special. So doctors have to find data to within India to produce compelling evidence. This is the most serious issue. Not climate change, not global warming. That's far away. This is affecting us today.
ongoing.
So is there any paper published from Indian data which shows clearly the evidence?
There is data in terms of the deaths that happen. That at particular times there's greater deaths. For instance, even around the Diwali time when you have more smog, there's some data to say there's greater deaths around that.
But I'm talking about longer one, annual and something, yearly.
Yearly, I haven't looked into that from a yearly point of view. I mean, we tried to look into that in Bangalore, where we wanted to see and attribute it to heart or cardiovascular deaths per se. The problem is a lot of the reporting is unstructured. When you have a lot of deaths that happen, invariably they just get a death certificate that says sudden death. So
But
if
we
you
get on the hospital data, not the certificate is always on the hospital, record everything down, right? There's some hospitals. Okay, you must have good data.
the problem with the hospital data is it's all non-electronic, not digitized. It's not digitized. So it's all paperwork,
Even today.
even today. So the first adopters of this have been some of the private hospitals. which have started digitizing their thing. But there's been a significant push from the government, I would say, in the last 10 years, where there's been a lot of emphasis on digital health. The Ayushman Bharat is one example of it. And even within that, you have a lot of ABA IDs and everything that is coming up. It's a process. I guess it will take time given the volume involved. Having practiced both in India and the US. In the US, if you have your cardiologist see 15 or maybe 20 patients a day, he feels he's had an extremely busy day. And it's a rare event for him to have seen 20 patients in his OP. In Jaideva sitting in the OPD today, I see at least 60 patients within a frame of 4 hours. The
That's
same
because
thing.
of the doctor-patient ratio, not because of average, right?
No, right,
Like
exactly.
fewer doctors in India compared to US.
Fewer doctors compared to the population involved, yes. And the same thing in PJ. I used to see 100, 120 patients within a span of 5 hours. So if you're going to add on digitization to it, the biggest grouse of doctors in the US has been that they spend a lot of time on digitization and paperwork today than talking to patients.
Oh,
So that is where you have a lot of funding coming in, even from the NIH, in trying to simplify some of the electronic health records they have.
Sorry to repeat, as per the, what the sir has raised the question. So central institution for consent, example, like means of TVS, they are constructing the digital one. Now, the process is already started. Sir.
Yes.
Now, the feeding the data, regarding that gradually when doctors also, I'm also a government doctor itself. So that already the process we are undergoing that training and also we are already adopting those things. But so far it will take a longer time to get the proper data. But already central government institutions, especially teaching institutions, that has been already started, but we may have to wait for the data to come up because ICMR collaborations are regarding those resources.
Yeah, I think the All India they started around 3 to 4 years back with
Yes, sir.
digitization.
Yeah, the data is now building up,
It's
but
building.
it will take some time.
Yeah. Yeah, as you mentioned, it's only been 4 years that the All India Institute in Delhi started the digitization, and I think IIC is one of the leaders or somebody who's been really roped in for the entire digitization.
Another slide, excavation of the data in relation to this kind of subject that requires a different forum rather than just only dumping the data.
Yes, that's the whole field of data science. That is.
Yes, sir.
Any other questions?
Sir, one thing for you. So
Yes, please.
As per the, see, as I'm associating with basic science also with the epigenetic models. So in the one of the slides I mentioned as external environment is internal environment and also external environment is physical environment. Internal environment you think of. Internally specifically I'm talking of cardiac myocytes with respect to ischemic changes. But is there any role? The epigenetic could be the answer in that group for this. Which if I'm not wrong, epigenetic point of epigenetic models, because we are working for cardiac myocytes and also as per the internal cell is concerned, cardiac myocyte, we have come up with some publications also. What is your comment upon?
No, definitely. Epigenetic changes is something that we are seeing. So initially you have the.
That is the ultimate what.
Yeah, so it is the response of the body to any change that is encountered. As I mentioned, whenever the change is slow, your epigenetic changes help to counter the change that happen in whatever adverse manner the change may be. Now,
Unfortunately, building up the pathophysiological mechanisms also, that plays a lot of what before.
yeah, because the change that has happened now, so you've changed your baseline from being A to being something else because of the epigenetic change that's happened. So that the epigenetic changes that happen is really an adaptation to the change that the cell or organ or the organism has been subjected to. Now, to what extent the compensation is sufficient really depends on how much time you're allowing for the change to happen. Now, if your change is going to be very rapid, the epigenetic changes happens at a very slow level.
Yeah, chronic.
Yeah. So it's a very long-term thing. Even when you say chronic, it's something we're talking about generations, right? To bring about a small change in the structure, right? Whatever you're seeing of the human structure today, maybe 500 years later, you'll see a normal human having a trunk on his head. That might be a change, an evolutionary change induced by certain changes in the genes that have happened. But for that to happen, it's a very long drawn-out process. But what has happened with our environment is it's been a rapid change over the last maybe 30 years or 40 years. that scale and the rapidity of that change is something that your epigenetic changes really cannot compete with in terms of the rapidity of this.
I don't know about this cardiovascular system is concerned. As far as the onco field is concerned, they're coming out with maximum complications for the body, so especially epigenetic change. I don't know about cardiac subject, but neoplasms come out with maximum neoplasm.
Thank you. If there are no questions, I again say that you brought the word circadian rhythm. That is the most important. Every species has got its own species. Keep your time. When to sleep, when to eat, when to play, and all of these. It's a must. We have to have it. I think last year we covered it very well. And also we covered about the light. Light pollution, blue light keeps you wake up. Red light, yellow light, go to bed. I think night bed light, don't have the blue light or anything like that. LEDs are good, but the blue tinge is the most dangerous. And also, most of us we project to the trees. So nearly over 1 million of birds die every single year because of the light focus on the trees. So this is what I just wanted to add to the. You brought it very well, as a matter of fact. And I think loss of 10 million trees is 6.7, not percent, the number increase in the death rate. And also Bangalore, we had 10 trees per person earlier. Now we got 1 tree for 7 people. I think we have to increase the greenness. Where the greenness is there, it has got a lot of social event, everything will come there, as a matter of fact. Especially handicapped people benefit much more than anybody else. And next is the noise pollution. I think 2003, Karnataka State of Environment Action Plan, I was the chairman of the health sector from the World Bank project, Karnataka State. We have mentioned the noise pollution is important and also how it affects the health related issue of that one. Some of the rules have come because of that one. And also bursting of the firecracker, not to certain decibels. That also the chairman of the TAC, Pollution Control Board, during that time brought that legislation. So bursting of only 2 hours, less than 80, 90 decibels, only for 2 hours to Diwali time. Diwali time, heart attack will be much more, mainly because of the sulfur dioxide content will be very high. That's water soluble, affect immediately. So next, I think you covered noise pollution. Traffic speed is, I think it is rich people contribute more to pollution than the poor people. So for 4 people, we got 4 cars. For party 1 car and this one car, if it slow traffic produces 5.5 times more pollutants. So this is what we have to educate the society in that one. There is no, and also I recommended to the central government that if they don't have a parking space in their house, don't allow second car to have it. But that's difficult to bring out the legislation, but it's a must. But we have got 4 people, 4 car, why do we need that? So I think these are all things covered very well. I'm very thankful for your time. And as a token of appreciation, please accept a memento, sir, Professor Srinivasan, sir.